So today I'm going to be talking about healthy brain aging, very important to all of us. And unfortunately, with that also comes a little bit about talking about brain diseases, the things that threaten healthy brain aging. So I'll talk about a little bit of both. So what is healthy brain aging? Well, all of us want this, right, as we get into our older ages. We want to continue to have the ability to think, to reason, to remember things, to carry out tasks, to live a purposeful life, and to live as independently as possible. I think that's our goal. We want to stay connected with our friends and our family, and we want to maintain our own sense of identity. So I think if we meet these goals, we'll consider that our old age is well spent. So I'm going to start first with some changes in the structure of the aging brain. There are some changes that happen. Certain parts of the brain actually shrink as we get older. And particularly the hippocampus, which is the center responsible for memory, starts to shrink as well. And this is why many people, as they get older, get those senior moments, right? Where you kind of forget a little something. But in the absence of disease, you can still remember okay. There is a decrease in neurons. These are the brain cells. And also the neurotransmitters, which is the chemicals that give messages between the brain cells. So we do see a slight decrease in these. And the volume of the brain and the weight of the brain actually goes down. So the brain is shrinking a little bit. Unfortunately, this starts in your 30s. Very, very slowly, but it does start in young adulthood. And it continues through old age. And then there are also changes in blood flow to the brain. There is also a change in what we call the blood-brain barrier. What is this? This is when you take medications, the same medicine that you took when you were younger may be fine. Now when you're older, maybe it has an effect on the brain that you don't want. Maybe some medicines for blood pressure might make you a little confused, for example. So we see that a lot in normal aging as well. And that's why we're very careful about what types of medications our older patients take. So what happens to your functioning, to your brain functioning? Well, there's a slight decline in ability to learn new things and to retrieve information. So for example, remembering names, finding words. As people get older, they might hesitate a little bit. They can do it, it just takes a little bit longer. I've had older patients they never got to go to college when they were young. They grew up on a plantation. They were taken out of school, actually, didn't even finish high school. They had to take jobs to help support their families. Now that they're retired, they decide, I want to go back to school. Some of them take adult education classes. They come back and they tell me, I can still learn. It just takes me a lot longer to learn now than it did in the past. You can still do it, just a little harder. You can also see a difficulty in multitasking, trying to do too many things at once. I'm one of those people who tries to do 50 things at the same time, sometimes not very successfully, so I got to learn to stop doing that. On the other hand, there's improvement in other areas. For example, people's vocabulary actually increases with age. Learning how to solve problems can increase with age. So this is kind of what we call wisdom, right? Your previous experiences give you certain knowledge that can be really helpful. There's also less improvement in impulse control and better judgment seen with aging. And so those things can help as well. So there are a few things that go down a little bit, but then a few things that actually improve in old age. You'll hear this term called cognitive reserve. This is basically the reserve function of the brain. And it's amazing, actually, how much the brain can sustain damage and injury and even illness before you actually see functional problems. Our brain is really plastic, and it allows us to compensate for a lot of things. So we can still function if certain parts of the brain are injured because other parts will kind of take over that function. Now, the more reserve you have, the longer it'll be before you see manifestation of disease. That's why we recommend that people build up as much reserve as possible. The analogy is in bone. Most people lose bone as they grow older, right? And in the end, the final result is osteoporosis. Now, when do you grow bone? In young ages and into young adulthood. The more bone you have, as you start losing, you need more time to lose before you fall into the disease category. Same is true with the brain. The more you keep your brain active and you build up this cognitive reserve, the longer you'll take to reach the disease categories. What we found is cognitive reserve has been associated very highly with education and with occupational attainment. So those of you who've had many, many years of education, as most of us in medicine do, that's been a good thing for your brain. So cognitive reserve may help your brain, what we call brain plasticity, which is ability to adapt to changes. So I'm going to go over some of these in detail, but in order to maintain brain health, there are 5 main things that I tell people that they can do. So if you look here, you want to maintain your physical, mental, and social activity. You also want to maintain good nutrition. A good diet is really good for the brain, just as it is for the heart and the rest of the body. And this is sort of relatively new. The heart disease risk factors. People used to think it's only important for the heart, and more we're realizing they're just as important for the brain as well. And I'll tell you some of our own research right here in Hawaii that has shown this as well. So let's start out with physical activity. Well, keeping active is really good for lots of things in your body. It can reduce risk of diabetes, of heart disease, stroke, even depression. People who are more physically active are less likely to develop depressive symptoms as well. So it's really, really important that we continue to be physically active as long as possible. Physical activity may also reduce falls. Again, a really big problem in old age. So we want to keep people from avoiding those falls. It may help actually improve those connections between the brain cells. The main thing I want to tell you is if you haven't been exercising and if you're going to be starting a new exercise program, learn ways to exercise safely and speak to your doctor before starting on any kind of even moderate or vigorous exercise because you may need some check before you do that. Now, what about mental activity? Well, it's certainly good to remain mentally active and to continue to perform mentally stimulating activities. People will ask me this, is one activity better than the other? And I kind of caution you, there are a lot of people selling things out now. You know, if you do these puzzles every day, you will not develop Alzheimer's disease. Or if you buy my book and do what I say, you won't. And to be honest, none of those are really true. But all we know is the more mentally active you remain, the better it is for your brain. But I can't tell you that one particular activity is better than the other. So what I say is, find something that you really like to do. It may be puzzles, it may be Sudoku, it may be anything, but remain as mentally active as possible. Reading is wonderful, playing different kind of games is wonderful. Virginia was telling me about a Pinochle club that she has. Start a club like that. I think that makes a lot of sense, and it keeps you not only mentally engaged, but also socially engaged. Volunteering is wonderful. It's a good way to keep your mind active as well. Again, not proven to prevent dementia, but it may be fun, and it may help your brain. So definitely worth doing. What about social activity? Well, we know that social connectedness is important for the brain as well. As people retire in old age, sometimes their world kind of shrinks and they stay home more. Now that's natural, but you can still remain very socially active in old age. In fact, with retirement, you have more time. So this is a good time to connect with old friends, with family, and try and do more. And it has been associated with reduced risk for certain health problems, like dementia and depression. Senior centers are a wonderful source of providing social activities, also physical activities. Some of those senior centers do multiple things. So I, again, strongly recommend joining one of those. What about nutrition? Well, again, common sense. A good healthy diet, lots of fruits and vegetables, whole grains, lean proteins, less sugar, salt, and saturated fats, and lots of liquids. Actually, the only diets that have been well studied have been the Mediterranean diet. And there have been some preliminary data suggesting that the Mediterranean diet may actually help prevent dementia and Alzheimer's disease. So the Mediterranean diet basically is all those things I already mentioned, right? Lots of fruits and vegetables and grains, and less of the bad stuff, like cookies and candies and saturated fats. This is really, really important. This is something that has been well shown that if you manage your heart disease risk factors, again, this is common knowledge. We all know this. High blood pressure is very bad for your heart. Well, it also happens to be bad for your brain. So it's really important that high blood pressure be controlled. Diabetes, good control of diabetes is important. Avoiding high cholesterol, avoiding obesity. Smoking is bad at any age, and anybody who is a smoker, I strongly, strongly recommend that they stop smoking. Not only for their heart, but now also for their brain. Staying physically active is really important as well. The big thing I want to point out is, don't wait until old age to control these risk factors. It's really important that high blood pressure, particularly high blood pressure and diabetes, you start good control in middle age. In fact, I'll show you some data from our study that shows if you wait until old age, it's kind of too late. You really need to start in middle age when these conditions first appear. So what happens to the brain with aging? Well, there's a big continuum. So here we have normal going all the way up to abnormal, and we have actually stages. This is the time when everything's good. Your memory is good, your intellectual functioning is good, and you're functioning perfectly normally. Then we go through a stage which is called MCI, or mild cognitive impairment. And at this stage, your cognitive functioning or your memory is getting a little worse, but your functioning is still not too bad. You're still able to do things for yourself, take care of yourself. But when we get into the dementia stage, this is where you have disease. This is where both the cognitive functioning gets worse and the function or your daily activities get worse as well. So I'm going to go through all of these stages and tell you what they mean. So again, when you talk about healthy aging, unfortunately you also need to hear about what threatens healthy aging, and that's dementia. There are some common myths about dementia. One is that memory loss is the same as senility, and it's an inevitable part of going old. People have asked me, even doctors write that in the medical chart. This patient is senile. I was very curious when I first heard that. I was like, what does this mean? I actually looked it up in the dictionary. Senile means old. So by saying old equals dementia, you're saying everybody in old age is going to be demented. And that's just not true, right? All of us have known people into their 80s, 90s, and beyond who are very sharp. I'll give you a personal example that was very, very embarrassing to me. I had a lady who was in her 90s. She was my patient for many years. And I used to see her about once a year. I'd do a memory test. I didn't suspect any problems, but I just wanted to see, is she staying good? So one time I did the memory test. She's in her 90s. I give her 3 words to remember. And then by the time it's time for asking those words, it was too soon because she was going through the test so fast. She was doing really well. So I thought to myself, I'll wait until the end of the test to ask those words. Well, I'm walking her out to the elevator, and she asks me, Dr. Masaki, when are you going to ask me those 3 words? I said, well, now would be a really good time. I'd completely forgotten about it. She hadn't. I don't know what that says about me, but her memory in her 90s was perfectly normal. Okay, so all of us know people like that. So by saying old equals demented, it's really not true. The second myth is nothing can be done for dementia. Now, I gotta say, our treatments for Alzheimer's disease are lacking. We really have not very good treatments for Alzheimer's right now. There's a lot of research being done in that area. But I hope at the end of this talk you'll believe me when I say there's a lot we can do for both the patient and the family and caregivers. The other myth is that most people don't want to know if they have dementia, and actually studies have misproven that. When we ask people when they're healthy, if you did develop dementia, would you want to know? Most people say yes, because they want to be able to plan for the future. So I think all of these myths contribute to the under-recognition of dementia. So what are the facts? Well, it's not normal aging. It actually represents several types of diseases. With normal aging, we talked about, you do see a slight decrease in ability to learn new tasks, but you can still do it. It's just a little slower. The other fact is that dementia is common, underdiagnosed, very expensive, and it's a fatal disease. And the other fact is that patients with dementia should have a good evaluation by a physician who's good at this, who's expert at this. So what is it? Well, first thing is you need to have acquired deficits. That means you need to see a change from previous functioning. For example, somebody who was born with mental retardation doesn't count as dementia because they were like that their whole life. This is where somebody changes. And previously they were functioning differently and now they're getting worse. You have to see a deficit in memory. So that's kind of the hallmark of dementia. But you have to have more than just memory. So at least one other brain domain, things like language ability or visuospatial ability or problem solving, one of the others also has to be affected. It needs to be bad enough that it affects your social or occupational functioning. So it's interfering with the person's interactions with their family and friends, or if they're still working, with their job performance. And you need to have an absence of delirium. This is the acute confusional state. When you visited older people in the hospital, have you noticed sometimes they seem very confused? Suddenly. They were fine before last week. Now they got a pneumonia, they're in the hospital, and they're really confused, and you wonder, wow, what is that? Well, that is usually a delirium. And fortunately, most of the time that reverses. So once that acute problem is resolved, the patients get back to what they used to be. The other thing is major depressive disorder or other psychiatric illness can also mimic dementia, so you have to make sure that somebody doesn't have that before you diagnose a dementia. I talked about this before, right? Mild cognitive impairment, or MCI. This is where we see a subjective complaint from either the patient or more often from the family member, a proxy informant. Usually the spouse or the son or daughter will say, mom or dad has some memory problems. And you see some deficits in testing in at least one domain. This can be memory, language, attention, various different domains. But your functioning is normal. Because remember, if you have functional problems, it's already dementia. So this is sort of like a pre-dementia syndrome. And there is a high risk of these patients to convert to Alzheimer's disease. In fact, they've shown in 3 to 5 years, half of patients with MCI will have a diagnosis of Alzheimer's. Well, that's kind of depressing, right? But what about the other half who don't progress? That's a really hot area of research right now because we want to find out, why do some get worse and why do some not get worse? What is protecting those people from getting worse? And how can we make other people do those things? So if you look at dementia, about 13% of people over the age of 65 have dementia. When you hit over 85, it's almost half. But it's not everyone, okay? We see a geometric increase in the prevalence of disease. After the age of 60, the prevalence doubles every 5 years. I'll show you this little graph here. So here on this axis, we have age, starting with 60 and 65, so it's every 5-year age group. And this is the percent of people who have dementia. This blue line here is people who have dementia bad enough that it's affecting their social or occupational functioning. So it's affecting their lives in a bad way. And you can see at 85, it's about 1/3 of people have it. This red line includes the dementia and the MCI, or mild cognitive impairment. And you can see again, after 85, here it's almost half. What happens after 85? Actually, people don't know for sure. The studies have not had large enough numbers to know what happens. Some studies show a continuing increase. Some actually show a plateauing and a slight drop. Sort of the healthy aging effect, the survivor effect. It's like once you've survived to those ages, you've kind of outlived some of your risk factors. So we're hoping our study here in Hawaii will actually show some of this because we have a very, very old population here. So one of the things about dementia is there's a long duration of disease. This is not something that kills you quickly. It does it very, very slowly. It's a major cause of disability, and it's the main reason for people being put in an institution. This could be a care home or a nursing home or some kind of institutional facility. It's the major reason. In Hawaii, I think it's predicted that about 80% of people in nursing homes have some form of dementia, and that's why they're there, actually. And it's a very costly disease, over $200 billion a year in direct costs, but even more important, the same amount in indirect costs. That's mostly linked to caregiving. How many of you in this room are caregivers? Can I see a show of hands or ever have been caregivers? I see some. Raise your hands. You should be proud of it. It's the hardest thing in the world to be a caregiver, and I really take my hat off to you. So the caregivers, too, have to sacrifice a lot, right? Some of them take early retirement. There's often missed work. So there's a lot of lost productivity, too, linked to dementia, and that's costly as well. And families really bear the majority of that cost. So what are the causes then? Now, again, this is something I really want to stress on because I've had patients come to me and say, Mom has Alzheimer's but doesn't have dementia. Well, that doesn't really make sense. Dementia is actually an umbrella diagnosis. Under dementia, there's several types of dementia. Alzheimer's happens to be one of the types of dementia and actually happens to be the most common type of dementia. Okay? But there are many other types of dementia related to stroke, things related to Parkinson's disease and other diseases. And so I'll go over these. And again, I want to stress some of these are reversible or treatable, which is why we really want to find these conditions early so we can treat them if we find them. So these are the major subtypes of dementia. And if you look here at this pie chart, the big blue wedge, which takes up most of the circle, is Alzheimer's disease. In Western countries, about 60 to 80% or 2/3 or so of dementia is Alzheimer's disease. Somewhat different in our Asian populations. Again, I'll go over some of our Hawaii studies to show you those results. The second most common is vascular dementia. That's this red wedge here. The next two, Lewy body dementia and Parkinson's disease, that's this little yellow wedge here. About 6% of all dementias. These are the Parkinsonian syndromes, where you see a lot of slowness of movement and rigidity of movement, and those can also cause a dementia syndrome. For Parkinson's disease, it's usually after having many, many years of Parkinson's that people then develop the problems with their memory and their thinking. And the last, this little green wedge, this is sort of the mixed dementias and other causes, some of which are treatable. So I'll introduce our study here. This is a study that's been done at Kokini for the last 50 years. It's the Honolulu Heart Program and the Honolulu Asia Aging Study. And it started in 1965 at Kokini Medical Center in 8,006 Japanese American men. Now, at that time, they were middle-aged. They were 45 to 65 years of age. Okay? And it started out as a disease of heart disease and stroke. But in 1991, the Honolulu Asia Aging Study began. At that time, the men were 71 to 93. And so people realized, wow, we have all this data from their midlife risk factors 25 years ago, and now they're getting into old age. What a wonderful opportunity to study the diseases of old age. So this includes things like cognitive function, dementia, depression, disability. And so that started in 1991. And they've had serial exams over the last 50 years. Can you imagine being in a study for 50 years? This is an amazing group of men. This is the second longest running study in the United States. The only one longer is the Framingham Heart Study from Framingham, Massachusetts. Currently, our youngest man is 95 years old. Youngest is 95. Earlier this month, we just had the 50th anniversary celebration at Kukini. So this amazing group of men, most of course have died, but we invited some of their children and their spouses, and some of the survivors still came. And it was really amazing to see that. So in this study, we looked at prevalence rates of dementia. Now you remember that line that I showed, right? Where it was kind of like a curved line, with the rates really getting higher with age. Every 5 years, the prevalence doubles. We found the same thing. On this axis here, we have the age groups. Our youngest was 71, and our oldest here was the 85 to 93 age group. And the blue bars are overall prevalence of dementia, and the red includes the mild cognitive impairment, or MCI. And you can see our numbers are very similar to the national numbers. About 1/3 have dementia that's severe enough to affect your functioning. And when you include the cognitive impairment, it's almost half. So very, very similar rates to the national numbers. But the next slide shows how we're different. So here we look at the dementia subtypes. Now I'll remind you of that pie chart that I showed, the circle where we had Alzheimer was this huge chunk, right? About 2/3, and a small little wedge for vascular or stroke-related dementia. Well, in this study, we found that actually Alzheimer's is still number one, that's the blue, but the stroke-related component, which is in red, is pretty close behind. In this age group, it's actually stroke is more common. As you get older, Alzheimer gets more and more common, but look, it's not like that big wedge and the tiny wedge, right? Stroke is very close behind Alzheimer's in some of these age groups. And this reflects other studies from Asian countries, from Japan, China, and Korea, where that the previous graph I showed you was from white populations. When we look at Asian populations, stroke-related dementia becomes more important. Many of these men in our study had no idea they had a stroke. They were tiny, tiny subclinical strokes. We only found them because when we found the dementia, we did a workup and we did scans. And wow, we see they had 3 tiny little strokes. They didn't even know they had it. What can you do to control these? Better control of those heart disease risk factors in middle age, right? The high blood pressure, the high cholesterol, the diabetes, those kinds of things. What about reversible causes? Brain tumors or infections like encephalitis or meningitis can certainly cause a dementia. I want to tell you, if any of these are bad enough or have been around long enough, they may become irreversible. So we really want to find them as early as possible, right, to fix them. I love finding these two. I love finding normal pressure hydrocephalus and subdural hematomas. What do those mean? Normal pressure hydrocephalus when you have too much fluid on the brain. Simple surgery, shunting away the fluid, can completely fix the problem. I love finding it. I rarely find it. Most of the time, I find Alzheimer's disease or stroke-related dementia. But when I do find this, I really love it because it's so treatable. Same with the subdural hematomas. These are blood clots around the brain, and a very simple surgery draining away the blood can fix the problem. So if I find these two, I'm always quite happy. Post-traumatic, this can certainly, if it's bad enough trauma, it may become irreversible, but sometimes people can actually recover after trauma. Thyroid disease. Thyroid is a gland that sits right here in the front of your neck, and a low level of thyroid can cause memory problems, which can be easily fixed. All you have to do is take one pill, probably for the rest of your life every day, but it's a cheap, very effective treatment. Certain vitamin deficiencies, especially B12 and folate vitamins, can also cause a dementia syndrome. Depression can actually mimic a dementia syndrome. I want to be a little cautious about that. So of course, whenever I see patients with memory problems, I'm always also assessing for depression. And if I find that the patient has some depressive symptoms, I'll try treating the depression. We have very wonderful, safe, and effective treatments for depression now. And then the memory gets better. So it's like, great, I fixed it, right? Well, studies have shown that sometimes this depression is a very early manifestation of dementia. And in 3 to 5 years, again, half of those patients may develop a dementia syndrome, mostly Alzheimer's disease. So it's not that I don't treat it. Of course I treat it, and I can buy maybe a few years of better quality of life. But I'm a little cautious with families and with patients about the prognosis because I know some of those may become a dementia. And then delirium is that acute confusional state from any acute illness, which hopefully will reverse. So let me go on then to Alzheimer's disease. This was first discovered by Dr. Alzheimer in 1906, and it was called a pre-senile dementia. The original patient was a 52-year-old woman who developed a very rapid onset dementia, very, very bad behavioral symptoms. She was psychotic. She actually died 2 years later. He got her brain at autopsy, and he discovered the plaques and tangles, which are to this day the hallmark of Alzheimer's disease. So over 100 years ago, this disease was well described. Very, very little research was done until about the 1970s or 1980s. Anyone want to guess why? Why did they ignore this problem for so long, for decades? Anyone? Okay, so one was they thought it was a psych disorder, that is definitely one, and then the other one here. People died before they reached the age where they got Alzheimer's. By far, the strongest risk factor for Alzheimer's is age. In 1900, life expectancy was, I think, 45 to 50 years. I know most of us are looking a little scared, right? Most of us wouldn't be alive in 1900. But as life expectancy increased, more and more people, so it went from being a very rare disease. In 1900, they thought this was a very rare disease. Now, it's a very, very common disease. So I think once people recognize, wow, as the population is aging, we better study this, more studies started happening. It's the most common cause of dementia, about 2/3 in Western countries and in Caucasian populations. Short-term memory is affected very early, also orientation, especially to date, and then problem solving. So these patients will often get very confused and disoriented early on in the disease. Behavior problems, unfortunately, are really common and very distressing to family members. In some studies, 70 to 100% of patients with Alzheimer's will have behavior problems at some point. Very, very slow and gradual onset and slow progression. You don't get a history saying this problem started in December of 2014. It doesn't happen like that. In fact, usually when we talk to family members, there's a lot of controversy. One says it started 2 years ago, the other was, no, I noticed something 4 years ago. Very gradual onset. It kind of creeps up on you. It has a long duration. I've seen patients who've lived with it for 20, even more, 25 years. Some people it's very gradual, some it's a little bit more rapid. The average is about 8 to 10 years from diagnosis to death. And this is what we see in Alzheimer's disease. We see a neurochemical abnormality. There's a particular chemical in the brain called acetylcholine, which transmits messages between the brain cells. You can see this here. It basically is giving messages between these cells. And that is low in Alzheimer's, and that is actually the memory chemical. That's not the only chemical that's low. There are others that are low as well, but that one is the main one. And that's why memory problems are sort of the hallmark of Alzheimer's disease. But it's not just the chemical imbalance. We also see this pathology. This is a protein called beta amyloid, and it's laid down in these sort of plaques. They look like little dinner dishes, right? Doesn't it look like that, kind of? It's an abnormal protein that's laid down in the brain. You can only see it under the microscope. And these are little tangles. They're like little twisty tangles that are also laid down in the brain. Together, these two are kind of strangling the brain cells. And what they're doing is they're causing the brain cells to die. So the neurons or brain cells are actually dying in Alzheimer's disease. Somebody mentioned they thought it was a psychiatric disease. This is not a psych disease. This is very much a medical disease. So what happens? This is a normal brain. This is an Alzheimer brain. Can you tell the difference? It's so much smaller and kind of looks shrunken, right? And that's exactly what happens. Brain cells are dying, and the brain is becoming smaller and smaller. In the late stages, it really becomes tiny and shriveled up. So what are the risk factors then? I've divided them into non-modifiable and modifiable. Among non-modifiable, age is the primary one. We have still not found a cure for aging. So age is by far the strongest risk factor. The next most strong, is actually a low education level. These two, in study after study, country after country, different ethnic groups, males, females, all of them have found higher age, lower education risk factor for Alzheimer's disease. There is a genetic susceptibility. There's this one gene called the ApoE4. Hold on the genetic questions because I'm going to cover genetics separately a little later. Traumatic brain injury could be non-modifiable, okay? I mean, if you get into a car accident or something. But it could be modifiable as well. I don't recommend getting your brain pummeled constantly. So certain sports like boxing, I don't get it. I just don't get it because you're constantly getting your brain pummeled. Have you seen, there's a lot in the news recently about football players. These young men, healthy, in their 20s and 30s, are getting these repeated concussions. And it's having a significant problem on their memories. And nobody knows what's going to happen to them long term. These are not reversing. Some of them are continuing to have problems even after the concussion resolves. It's not good to get your brain pounded constantly. That's the bottom line. So if you can avoid it, please do. Family history of Alzheimer's and family history of Down syndrome are a slight risk factor. Part of the thing about the family history of Alzheimer's, in the late onset Alzheimer's, which is the most common type, part of it is longevity. Think about it. What is the biggest risk factor for living to a very old age? It's having mom and dad or brothers and sisters who live to a very old age, right? By far, longevity is very familiar. So if you happen to be in a very long-lived family, you will have a lot of older relatives. What is the biggest risk factor for Alzheimer's? Age. So you just have more people in your family living to the Alzheimer's risk age. So part of it might be that. And I always tell people, please don't change your behaviors based on just having a family history of Alzheimer's. What about the modifiable? The cardiovascular risk factors, we talked about that. Treatment of high blood pressure, of diabetes, even of things like sleep apnea is really, really important. Dietary factors. Heavy alcohol is not good for the brain. And in fact, we see irreversible dementia is linked to heavy alcohol intake over many years. Now, I don't drink at all. It's no reason, I just don't like the taste of alcohol. So I used to think, oh great, I'm doing something good for my brain. It actually turns out slight drinking is better for the brain than not drinking at all. Yes. Now, by slight drinking in old age, that means one drink. And I mean one drink, not one drink, okay? So it needs to be really small amounts of drinking. It's actually a little bit better than completely not drinking. And in any types of drinks. Some studies have suggested red wine is better than others, but to be honest, any type of alcohol. In some of the studies we've looked at, any type of alcohol, but tiny amounts is good for the brain. Once somebody has Alzheimer's, though, I recommend that they stop drinking because the blood-brain barrier has changed, and even small amounts of alcohol can make those patients very confused. So I'm talking about normal people, okay, normal healthy brains. Depression, we've talked about already, and then chronic inflammation as well. So I'm going to show you some of the data from the Honolulu Asia Aging Study. We looked at a cross-sectional association of memory problems with high blood pressure. So here I've got the 4 blood pressure categories: low, normal, borderline, and high. And this is basic baseline risk. Anything above means a higher risk. Anything below actually means a lower risk. Lo and behold, we found high blood pressure protects against memory problems. How can that be? That doesn't make sense, right? Well, fortunately, our study had information from midlife. And that's the next slide. And what we found is when you look longitudinally, we found the exact opposite pattern. Same 4 blood pressure categories, but you see here, as the blood pressure gets higher, higher and higher risk. With the high blood pressure in midlife, people had a 2.5 times increased odds of developing memory problems in late life. If it was never treated, it was almost 5 times the risk. So what does this tell you? It was too late for these people. The late life blood pressure wasn't a good reflection. It was really in midlife that the blood pressure should have been treated. So people looked at the study and they said, well, it's all stroke related because we know high blood pressure is linked to stroke. Well, this is what we found. We had an autopsy study in the same program, and we found the same 4 blood pressure groups, and they had not only stroke, but they had higher levels of plaques. That's the hallmark of Alzheimer's disease. So they have more stroke, but they also have more Alzheimer's disease. And here, this is the good news. Same 4 levels. Again, you see higher risk in people who have high blood pressure, but this is the untreated group. When we treat the high blood pressure, it doesn't increase the risk. So it shows that we can actually do something about it. If high blood pressure in midlife is treated, it actually reverses this risk of having more dementia. What about physical, social, and mental activities? Well, we looked at that too in this study. We looked at walking. On this axis here, this is the highest walkers. They walked for more than 2 miles a day, and this is the lowest, less than 1/4 mile a day. And you can see as you go from high walking to low walking, more and more and more risk of developing dementia 8 years later. Almost double in the low walking group. Same thing with social engagement. This is the high social engagement, little less, low. You can see higher risk, over double the risk in the low social engagement. So again, showing the importance of remaining physically active as well as socially active. What about genetic testing? Well, there are 2 types of Alzheimer's. Late onset, which is the more common one, or early onset. Early onset is very dramatic. These are people in their 30s, 40s, and 50s who develop Alzheimer's disease. You cannot miss it. For those, I definitely recommend genetic testing. In fact, I recommend genetic counseling for the whole family. Those are autosomal dominant genes. What does that mean? If you have the gene, you will get the disease. It's 100% odds of getting the disease. Fortunately, very, very rare. Less than 5% of all Alzheimer's is this type. Okay? The majority is this type, the late onset. There is one gene that's been found to be a risk, but it's not a guarantee. You can have the gene and not get the disease. You can not have the gene and get the disease. I don't recommend routine genetic testing. This is more for research right now in this group. So early detection is really important. Why? One is you want to treat those reversible causes. Also, it'll improve treatment of underlying conditions. Remember, people with high blood pressure, with diabetes, they need to do things to take care of their own health. They'll forget that they took their medications and take it over and over. Or they'll forget to take it in the first place. So it's really important that they be monitored. We don't want to have this crisis-driven care where these patients are showing up in the ER or in the hospital because their dementia has not been recognized. Also, we want to provide patient and family education. These patients deserve to be able to plan for their own care, right? They need to do their advanced healthcare directives, maybe do some legal planning, financial planning, those kinds of things. Safety is a big issue, and then, of course, we want to connect to community services as well. So this was our study where we had no dementia, MCI and dementia, and we asked the caregiver, does Mr. X have a problem with his memory or thinking? And the red is they said no problem. Even among the demented, where they were functionally impaired, 20% said no problem. Among the MCI, half said no problem. They're not picking this up. And when we asked were they referred to their physician for memory problems, among the demented, 40% were not referred. And over here, only 5% were seen. So we're not picking up these patients at all. And the doctors are not doing a good job with this as well. So we're really trying to do a lot of physician education, too, about recognizing this dementia. This was one of my previous fellows, Dr. Valcor, who's now at UCSF. He did this study. He looked at a private practice group in Hawaii. And he found 2/3 of all dementia was missed. Among mild, 90%, among moderate, 50%. None of the severe were missed, but I don't think we should be proud of that, right? Anybody can pick up severe dementia. So it's a real big problem. It's not detected. What are the symptoms? It affects your activities of daily living, your behavior, your intellectual functioning. We always look at caregivers and caregiver stress. Unfortunately, disease progression is inevitable, and at every visit, I try and do a little bit of education. So in the early stages, we see short-term memory loss, disorientation, problems with naming. People will have trouble remembering names or naming things, but they may still have insight and may still be able to compensate. And you see associated depression. In the intermediate stages, now it's not only date, but even place. People may become very suspicious, paranoid. People can have personality changes. It can be a really big problem for families. And at this stage, I think people need constant supervision. At the late stages, people may even wander. Long-term memory is even gone, and they're totally socially inappropriate at this point. So for the diagnosis, I usually do a complete history, including medications and alcohol, the functional status, the living situation, a physical examination, memory testing, and then we do blood tests for those things I told you are reversible, right? Things like the thyroid and the vitamins that are deficient, to see if any of those are abnormal, as well as a brain CT or MRI scan. For treatment, our goals are really to enhance quality of life and maximize function. A lot of this is done without drugs. There are some drugs that we can use, but most of it is done without the drugs and managing the symptoms. We usually use an interdisciplinary team. The physician alone is not enough. We need help from social workers, dietitians, and other professionals. Regular medical appointments. Environmental modification is really important. Let's say somebody is so confused that they're getting lost in their own house, they can't find the bathroom. Put a picture on the door of the bathroom, or put a sign on their own room saying Daniel's room, so that they can find it easier. Just simple things like that are important. Legal planning, caring for the caregiver. I do want to say in geriatrics, AA is not Alcoholics Anonymous, it's Alzheimer's Association, okay, always. So these are some of the safety issues. Medications, wandering is an important factor. The Alzheimer's Association has a safe return program. You can register your person in. Things like the stove and water, driving. These patients are at risk for elder abuse as well, so we really need to watch over them. So in summary then, diagnosis early, treatment of the cause, treatment of the complications, providing a safe and stable environment with education and a team, and planning for the future. So I've got some resources in your packet about the Alzheimer's Association. Also this resource that you can look on the internet. It's the Healthy Brain Initiative from the CDC. And I'll stop here and see if people have any questions.